what we wanted to talk about was a little bit different, but I think it's going to answer a lot of questions. So what I've heard this morning and this afternoon, and we've heard kind of over the last couple of AI Med conferences that I've attended, is a lot of this is great in theory, and some people are trying to do it, and we're an organization that is looking at data very differently and actually deploying it and have built a model of care around it. Alignment Healthcare is a Medicare Advantage plan in California. We hold the Knox-Keene license in multiple counties. We serve about 50,000 Medicare covered lives. In North Carolina and Florida, we are actually a risk-bearing organization where we bear risk from Blue Cross Blue Shield of Florida, Humana, and First Carolina Care in North Carolina. And when we started this company 4 years ago, I was the 20th employee. And the reason why I was brought on as a clinician was to answer the question of, can we use data and data science to put it in the hands of clinicians to really understand what we need to do for our senior population, and by providing healthcare to them and triaging them in a way through what we call our clinical command center, which is our informatics center, can we provide lower costs by increasing quality? So what did we do is we had no patients, and now we have 50,000 4 years later. We went from buying a 3-star plan, which if anyone knows anything about Medicare stars, 3-star plan is somebody who's probably not going to be here next year. And we've turned that around to 4.5 stars, which means that the quality improvement had to dramatically increase. We built a team, which I am very proud of, and 2 of my team members are here, and you'll hear about other team members who are not, and looked at how do we get information to clinicians who are not only seeing the patient, but also clinicians that aren't seeing somebody today, but maybe need to see them tomorrow. So we've coded hundreds of thousands of rule-based algorithms that run on a daily basis. Actually, every 15 minutes, it's queuing to look for more information. Because we are the health plan, we have the patient's pharmacy data. There's actually only 1 or 2 places in the country I don't get pharmacy data, and that's the VA and an FQHC that has a dispensary, or if you gave a free sample. Lab data from Quest and LabCorp and all the small vendors, EMR, claims, encounters, ADTs, CCDAs, and build our model of care, which is we have nurse practitioners, PAs, physicians, primary care docs, who are actually seeing these alerts and being told, hey, this person is, we believe, to have advanced illness through our predictive analytics, and we believe that this is what this patient needs. You go out there. And I think something that we've talked about for the last hour, a couple of hours, is, well, there's alert fatigue. There was a clinician in the back that was worried about that. The other was, I got an alert, now so what? What do I do about it? And a lot of the way we've looked at it, and I'm going to turn it over to my colleagues here in a second, is tell the clinician why. So when we looked at our first AI models, we deployed something called Lime theory, where you're actually giving a response and the likelihood of why the artificial intelligence came up with a specific alert for you. And so with our Falls model, which is one of our newest models, it actually tells you the reason why we think that this person is going to fall in the next 90 days is because the number one thing was that the patient yesterday picked up a new prescription for a prostate medication, which happens to be an alpha blocker, and he looks exactly like somebody, multiple people who have fallen in the past, and we actually deploy somebody to do education and go forward. So we also look at how we work together as a product team and creating products around our data science and what we're going to do. I work with our team on a daily basis. I'm still a practicing physician. I still see patients in the hospital setting. I still do my medical director work as well with utilization management, but I bring a subject matter expertise to our data science team. And by working together and doing daily stand-ups on a day-to-day basis with our UX, UI, designers, with our data scientists, and our product managers, we actually go through what are we going to do, what's our plan for the next sprint, and we actually put out a new iteration of our product every 2 weeks. And I'm going to turn it over to Joelle, who will talk a little bit more about how we do all of this together.
Thanks, Arda. So I have the unique pleasure of having access to a doctor as a product manager every day. And so I'm going to talk a little bit about how we have applied proven kind of product and solution development frameworks in a setting to make data science and AI and machine learning a product. So Arda spoke to our framework a little bit. We have a cross-functional team that we have dedicated to our clinical command center that's comprised of data engineers, data scientists, software engineers, experience designers, and also Paul, who's kind of our ace in our pocket here. Paul is an awesome product owner who manages our backlog and maintains the product strategy and roadmap, working with Arda. And each day, this team works together to continue to build forward all of the new functionality that we're currently building in Command Center. So I think someone in the audience was a UX consultant. I wanted to make sure we brought up that this is a person who participates in this team on a daily basis. And part of what we've done is actually gone out with our clinicians into the field and done comprehensive studies with them on what their day-to-day life is like, observing them interacting with our patients in both clinical settings and in our patients' homes, and then understanding how they need to interact with information. And so we can ensure that we're designing both workflow and software and displaying insights in a way that makes it actionable and consumable for them. And really keen to this idea of right time for actually receiving this information. So I think one of the important things that we start with is we are constantly focused on delivering tangible business value every 2 weeks. And so our ideation phase is really about answering two different questions, either what's the problem we're trying to solve or the question that we're trying to answer. And as we start to hone in on what those specifics are, this gives our team the ability to start to understand, okay, what's the data that we would need? We heard a lot about, do we have enough relevant data? What's the data that we need? How would we go about even solving this? If we were able to come up with a model, so for example, we discussed the Falls model, what's the workflow for actually getting that deployed so that either our case managers can use it or our physicians who are actually seeing patients are able to do an assessment? And then ultimately, what we are designing for is really two users. So we have a clinical team that will be receiving this information that they'll then take action about. But in addition to that, long term, we're working toward actually being able to share this information with patients as well in a patient-friendly way. And so we are constantly focused on how do we ensure that this information meets the needs of the person who's going to be using it? And I think another process that we've put into place is this idea of being comfortable with iteration. And so we work in a framework of progress over perfection. Let's get something out and figure out how we can learn from that and feed that back into our funnel and continue to enhance. And so there was a bit of trepidation at first around can we trust this predictive model, right? And we have a lot of clinicians, of course, who are keen to understand how these concepts work. And so we started with something that we considered relatively low risk. It's a Falls model. And because we're able to demonstrate to them the why, we've noticed that that's a major adoption factor. But in addition to that, being able to have a feedback loop so that we can understand both the model gets smarter, and in addition to that, we have feedback from our users on how they would like to consume this information. Another important part of our strategy is that we are building our models in a way that's similar to like software development principles and the concept of build once, use many. So how do we take these insights and information and actually spread them across the enterprise so that people can consume them through a variety of different tools and solutions? So we actually have a clinical command center application, which is the primary place where these are being used. But ultimately, if we want to start sharing these alerts or these insights with clinicians that are outside of Alignment Healthcare, who are our provider partners, how would we do that? Could we do it through a portal? Would we use it, push an app out to them? And so designing with this idea of being able to continue to grow the population of who's actually using these insights. And so really the whole premise is, can we take a working backwards, product development process that we have seen be successful in other industries and apply it to how we are approaching leveraging data science within our organization so that we can ensure that it derives tangible value for both our clinicians and also our patients.
And I think there's an important piece to that as well, is that, as we put out new models and you're being queried as a clinician that, hey, this patient's likely going to fall, or this patient's likely going to be admitted in the next 30 days. It's still in the hands of the clinician to make the judgment of, okay, well, what do I do next? I'm getting some information from the machine learning algorithms that's saying X, Y, and Z, but then we've also created in the command center, it almost functions as an HIE, where you have the most up-to-date labs, the most up-to-date pharmacy data, claims, encounters, and all of that coming in to where you actually know a lot more about that patient than you would have otherwise. And oftentimes we know more than the primary care provider, because as the patient utilizes, you have to remember that we are the health plan, and the health plan gets all of that information. And we've actually strategically contracted so that we can get that information from hospitals on a daily basis. So, with our hospitals that use Epic on a nightly basis, I know every procedure you had. I know every diagnosis code that went into your note. I actually have some unstructured data that's coming out of there, your CPT, what was dispensed, what was not dispensed, and that actually runs through the algorithm sets that allows us to not only visualize, but then make a decision clinically on the alerts that are coming to us. And so it's really important that clinicians continue to be working, again, side by side. There's that fear I still hear of, oh, well, our jobs are going to be lost, and that's absolutely not the case. I think it's going to drive efficiency, and what it's done for me personally is that it's allowed me more time to spend with the patient and actually have discussions that we need to have in that face-to-face. And that's worth its weight in gold, as most of you know, because I doubt, other than those of us who are physicians, you don't spend more than 5 minutes with one. So you don't have that luxury anymore, and this will really help drive efficiencies. And Paul, I don't know if you want to talk a little bit about how we work together and our daily stand-ups and what we try and do.
Sure. One of the most important things is that, like we're starting out with problems that are fairly big and involved, right? You have to find some way of chopping these down into, we use a 2-week increment because we use the Scrum methodology, and that tends to have what we call sprints that are 2 weeks long. And so what you want to try to do is you want to try to produce a meaningful piece of the overall solution every 2 weeks. And then when you take that meaningful piece, you want to be able to put that in front of somebody who's going to be using it in the context of the overall solution and get their feedback before you go any farther. Because you don't want to put any kind of investment into something that will eventually be wasted, even at a very small level. Yeah. So this relationship that Arda and I have, that we also have with every other user that we anticipate for the product that we're building, this relationship is really key to ensuring that none of our time gets wasted.
Yeah.
Yeah, we've been able to make significant progress with a finite amount of engineering resources as well because we are constantly receiving user feedback, and so we can continue to hone what it is that we're putting out. There's no black box in engineering where people go away for about 6 months and then come back with something. We always talk about how product development is a team sport at Alignment, and we have, at the end of each of these sprints, we do demos, and anybody is invited to come and participate in the demo and provide feedback. And Paul serves in a role of being able to kind of consume that feedback and digest it, work it into our backlog, and then partner with Arda and the team to figure out, okay, how do we want to actually apply this to the solution that we're building. And I think one particular important facet of the Clinical Command Center is that we genuinely believe that the purpose behind this solution is to actually facilitate a more meaningful human interaction between a provider and a patient. So it's technology to actually facilitate human connectedness. And so our whole goal is we want to get Arda the right information that he needs to know about that patient at that time so that he spends less time clicking through his 6 different applications and more time actually engaging with that particular patient and evaluating what it is that they need in terms of intervention and next steps for their care.
Yeah. And I think a piece of advice that I'd give before we wrap up to give some time for questions is that if anyone's thinking of doing this and developing an ROI around it can be quite difficult because you have to ask yourself, is it the human interaction that helped drive the ROI? Was it the alert that you got that led to that human interaction that drove it? And so when I had to make the business case 4 years ago that we need to invest in building our command center, what I said was, this is what I think we can do. I think we can decrease utilization and hospitalizations by 20%. I actually got laughed at. I literally got laughed at. And I said, I think I can bring our star rating up, which is going to impact revenue. And I think I can help in the missing diagnoses that our patients are not having captured through the understanding of this data. And so what happened? So over the course of 4 years, we're now $750 million in revenue. We are 4.5 stars, but what's the most impactful in all of that is the fact that our admits per thousand in our population who are seniors, chronically ill, is the lowest that in the 10 years that I've been practicing with this population, the lowest I've ever seen. Last year, we closed California in 7 counties, including LA, Orange County, which traditionally, if you are in the East LA area, has a very sick population, are running admits per thousand in fee-for-service Medicare of 220 to 240. So 220 to 240 people per thousand are being admitted every month. We closed out the year last year at 170, and this year we're closing it at close to 150. So those are about 70 lives per thousand that are not getting hospitalized because they're being provided the adequate care that they need. They're being identified. But what does it mean financially is if you look at our California cost, and this is a real number, our average cost per hospitalization is $14,000. So if you extrapolate that out, we're saving the company millions of dollars through minimal investment back at doing the right thing. I always say that we have a very interesting dilemma in this country. We call healthcare healthcare. I don't think it's healthcare. We do sick care. If anyone can convince me otherwise that we provide healthcare in this company, I would love to have the argument with you because we provide sick care. We wait for people to get sick before we do anything. But by understanding their data, their not only their healthcare data, but their socioeconomic status, their healthcare, their social determinants of health, all of that we've found ways to digitize through health risk assessments, through purchasing of some of that data from outside vendors, and utilize that to get a more holistic view. I think it will improve as we bring in things like genetics. We have better understanding of behavior. And I believe in the last talk, Layla was talking about the, having an Alexa device. Building those skills so that you can interact with that person with their information intelligently in a way that's culturally competent and has some human emotion, I think it's possible. I don't think it's that far away. And it's something that we're striving to do. So with that, I think we've got about 6 or 7 minutes for questions for our group before we move on to the next group. And so we'll field any questions that you have.
First of all, that just made my heart sing. Like, I think from one fellow UX person to another, and a lot of the points that you guys touched on in terms of like the patient and healthcare and sick care, I think are super important to be discussing within the context of AI Med. My question is for you in terms of how are you prioritizing the feedback that you're getting for the algorithm versus the design?
You know, it's an interesting question because, you know, like, we practice design thinking. So we do a lot of in-depth, deep dive into the lives of our users and the people that we anticipate will be using the product that we're building to try to get some sense of what they're trying to get done. And you learn a lot from that. But once you show something like an artifact of something being completed, that will inspire other thoughts in the minds of the people that you're trying to develop something for. And it will take it in an unanticipated direction in most cases. So we are always in the situation of having to look back at the original mission and ask ourselves, is this even still relevant? Have we been given an insight here that justifies a major change? Or is this a new idea that we should put into the backlog of work that we want to do in the future and then bring it forward? And, you know, I think that, you know, the answer to that dilemma is not simple, right? I'm sure we all can appreciate that. And we just do it in collaboration. You know, like, here's the situation, here's the new insight, what do you think? And that's the way we resolve it, and then decide if we need to do something much different, or if it's just going to be an enhancement that we do in the future.
And we invite all stakeholders to the product grooming for the next sprint and the product demo. And so we, you know, Amazon functions in something called pizza teams, right? So if you haven't heard it, it's a small enough team that 2 pizzas can feed. And so we have a functional lead from every part of the company that sits on this pizza team for Command Center, and they are there to represent that line of the business. So be it claims, member experience, utilization management, and so that they all have equal input into what it is that we're trying to drive so that we can make the most impact to the organization and the patient population with every 2-week sprint that we go through.
Great. So a question on that. First of all, love the product management perspective of the data because certainly near and dear to my heart. So hearing the sprint and the methodology you're applying. 2 questions. One of them is sort of a short one a little longer. The first one, are you getting real-time CCDs from clinicians, not just hospitals, but actually the ambulatory folks?
Yeah, so in North Carolina, 70% of the network we are daily getting CCDs. Okay. Florida, it's about 40%. California, we are actually working on a data strategy right now to go towards 90%. You'd be amazed how many vendors there are out there that have very interesting contracts in place with large organizations to be able to transfer data. And if the member is yours, we've also been very humbly intelligent in how we've put forward our contracts with our members. So members have to elect to be a Medicare member with Alignment Healthcare, and there's actually a stipulation there that their healthcare data can be transferred into and out of institutions to us.
You have their consent, basically.
Consent is exactly it, yes.
And then the other one, so every 2 weeks you're releasing something. Is that just on the analytics, or is that literally everything on the product, like the web UI, the munging the data?
It's everything.
Depends on
Depends on what's on the list for that sprint.
We have one more question over here.
A great presentation. Thank you. I think I heard you emphasize the importance of improving the interaction between the physician and the patient. Mm-hmm. And I heard wonderful metric outcomes, but I didn't hear anything about the interaction between the physician and the patient, or maybe through the lens of the physician. Mm-hmm. So what can you comment on as to the experience that the physician has, the multiple alerts that you addressed at the start in terms of alert fatigue, And/or if this is off-site to an actual patient in front of you, how do you prioritize time if you've got patients to see in front of you and then accumulating alerts for patients that aren't in front of you?
So in the design, we designed the alerts to bring out what is the most important to impact on this member at this moment, based on the information we have. Not just the chief complaint of why the patient might be there. We may have actually proactively gone out to see the patient because of the alerts that we've seen. And each one has a workflow, but they are something that I think any of us as clinicians, when you look at, you'd be able to do fairly quickly. So for example, if I have a diabetic patient in front of me, the alerts that are almost kind of jumping out of the page at me are that the patient's A1C is 9.2, that they didn't pick up their medication last week, and they're overdue for that medication. They haven't picked up their insulin for a month, so there's an issue there. And the patient has a wound that I may or may not know about. So it's put a lot of information in front of me that I think those are all correlated, but I didn't have to go digging, and it can help direct what I'm asking the patient about and going through. I can give you a very, probably this is pretty anecdotal, but what happened to me 6 weeks ago. So I'm based in Orange County. I get a ADT feed from a hospital in Santa Clara County. We have a contract with that hospital, but I don't have privileges at said hospital. I get a ping in real time that a patient entered the emergency room. I call the ER about an hour later and do a doc-to-doc with the ER physician. Patient had been there for shortness of breath and had a pulse ox at home, which he said was in the low 80s. He got a breathing treatment, chest x-ray was normal, and he feels fine. When I looked into our command center, I had an alert in regards to a medication that the patient had been taking, but no diagnosis associated with that medication. And the medication happened to be Coumadin that he had filled a year ago and hadn't taken anymore. So as I spoke with the ER attending, I said, do you mind asking this patient, because I can see an alert here. This patient's only been ours for about a year. He had Coumadin at one point, but I don't see anything about DVT or pulmonary embolism or anything like that. He put me on hold, spoke with the patient, and the healthcare literacy of this patient was pretty poor. Came back and said, patient said he was treated for 6 months for a DVT a year ago. I'm going to scan him. Turns out this patient had 4 PEs, and it's kind of a miracle. He was satting normally, but that's likely what had happened in the morning is he threw a PE. The plan for the ER physician had actually been discharge at that point, prior to my intervention. That changed the dynamic of my relationship with that physician, but also a patient I've never touched before, because the information was there. And when I'm on call or our physicians are getting this information, a lot of it is the fact that the information is there and that I'm able to do something with it. So I think a lot of us who practice in a closed network or in an open network, you don't really get to, you repeat labs, you repeat radiology studies and things like that because that information's not there. This has put it in our hands to where not only does it tell us where it was done, and we may have it, or whether it was missing and it was appropriate to have, it makes my life a lot more efficient so that I can focus more on the patient. And with our remote home monitoring that we have, we can actually do what someone was mentioning before, is adjust the parameters so that if 91% pulse ox is normal for you and you have COPD, I can not have that alert anymore. I can have it alert when you drop into 88 or whatever it might be, and wait for you to say that I'm very short of breath today in your care plan, which will then send me an alert.
My name is Penny Joan. I'm Children's Hospital Colorado. I'm actually very privileged and honored that the organizing committee invited me here. I actually have a problem that I hope the audience and my data scientists here can help me answer, because this is a question that, as pediatric cardiologists, this is what we're lead to. So I'm going to show you this video. It's actually the heart model, which is anatomical intelligence that's been put into reality. So if you look at the heart model, so it maps out three-dimensional echo parts of your heart. Okay, you can see the left atrium, the left ventricle, the aorta, the right atrium, the right ventricle, as you can see that it's mapped onto fluoroscopy, which is what we call fusion imaging. So this is actually really easy to use. It's fusion of 3D echocardiography onto X-ray, so plain X-ray. And if you were a fellow who was learning right heart cath, this is very helpful because you can see where the catheter is going instead of guessing where the heart is, okay? So, and you have rotation, and you can see the three-dimensional image where you don't have to guess anymore where the right heart or the left heart is. And when we do a transeptal puncture for the interventionalists, they typically ask us, where's my catheter? Is it at the atrium? And so in using this fusion imaging, we can completely tell them this is the spot where you need to go. You can place markers on these, and then as you can see that they can go into the left atrium quite nicely. So this is just an overview of a heart model, anatomical intelligence for the adult hearts, and it plays in reality for the adults. But for pediatrics, this model falls apart. So if you look on the right-hand panel, the purple is supposed to be the left atrium. However, it thinks the left ventricle is the left atrium. So my question that I had when I met Dr. Chen in Bali, and I showed this to him, he said, why don't you pose this to our data scientists? So I am going to pose this question because the heart model works in the adult hearts, but it doesn't work in the pediatric hearts. And how do we, in pediatrics, we don't have thousands of data, so we only have limited data. So how do we use limited data for machine learning? And how do we use limited data to utilize this for our pediatric population?
Hi, I'm Allison Hill. I'm a pediatric electrophysiologist, which in regular language means I'm a heart rhythm specialist for children up at Children's Hospital Los Angeles. And I was also tasked with describing a clinical problem that could potentially lead to some solutions with all the brains in this room. So I'm going to guess that probably 1 to 2 people at each of the tables here has had symptoms suggestive of an arrhythmia. So somebody at your table probably has felt palpitations or shortness of breath or dizziness, or they felt like they were going to pass out, or they did pass out. So these are symptoms that very frequently patients come to my clinic, and I'm sure general internists as well, describing. And typically, historically, what we've done is we've prescribed some sort of an arrhythmia detection device that looks something like this traditionally. There are many different varieties, but ultimately we prescribe this device that the patient then wears for a prescribed period of time, anywhere from 24 hours to maybe a month. And then we hope that the patient experiences the same symptoms during that time period. And if he or she does, they press a button, something gets recorded, the information eventually gets sent back to a central data repository, essentially, or a company that interprets the data, and based on set notification criteria, notifies the provider whether it looks like the patient has had an arrhythmia or not. So there have been significant advances in pocket arrhythmia detection, especially recently. So just over the last couple of years, there's been this device that allows for patients to use a different band on their Apple Watch, which I'm sure many of you guys are wearing right now, to record a single lead EKG. And this device has been out for about 2 years. And then most recently, just last week, Apple released their new app for the Series 4 Apple Watch that allows consumers to just put their finger on the dial on the end of their Apple Watch and record a single lead EKG. And this is obviously a consumer-based product, and so it offers a lot of benefits. Certainly it allows for unlimited time that patients have to detect their arrhythmia. So if they don't have their arrhythmia or their symptoms within 1 month or whatever the prescribed period was for their detection device, they can still hopefully at least record an EKG during their symptoms. It also allows for patients to potentially be more involved in their own healthcare. If they're, having to open this app and record something, it's very easy, it's very convenient, and it's relatively cheap. However, there are several challenges that I think that this presents, mostly because this technology has really outpaced our infrastructure for the information that we're going to be getting from this technology. And I can tell you, as an electrophysiologist, I've already gotten tracings from these devices, many of them, some of them showing real arrhythmias and some of them showing garbage, to Dr. Wetzel's point earlier, the garbage in, garbage out. So some of the challenges that these devices and the information from these devices bring up are that we really don't know what the specificity and sensitivity are from these devices for arrhythmia detection, certainly in adults, but especially in pediatrics, where the where the rhythm algorithm is really only applied to look for one type of arrhythmia, which doesn't really happen in pediatrics. That's atrial fibrillation. Another challenge that these devices bring up is that there's really no infrastructure to store the data that these devices are bringing, to analyze it beyond essentially one algorithm that looks for atrial fibrillation versus not, and there are many other types of arrhythmias. And there's really no infrastructure right now to avoid overburdening providers, because patients can essentially do what they want with this information that they record, and as of right now, they're just my patients are emailing me this information, which is excessive. And then the last challenge that I think this brings up is that as an arrhythmia specialist, these devices offer a great opportunity to learn more about arrhythmias, the development of arrhythmias, and what even smaller burdens of arrhythmia mean for patients in the future. So I think that these are the challenges that this particular type of device are going to be bringing to us, and I really welcome all of your thoughts and any of yours to help think about this problem.
Oh, there we go.
Well, yeah,
Look
just
at that.
had a little bit to share. So I think the problems you're mentioning are sort of generalizable to what do we do when we have models trained with one kind of data that may not apply to other kinds of data. So this paper just came out very recently where they were looking at pneumonia screening with chest x-rays, and what I think is interesting in terms of your questions is that the single center quality of inference was really good, but when the models were exposed to unlabeled data from other centers, the inference quality went down very significantly. So just from my perspective as a geek and infrastructure person, what we need to do is take this AI research that we're all here talking about and democratize it, make it clear to everyone that we're never going to be able to solve these problems unless everybody's part of the solution, that everybody needs to be doing this kind of research, especially because it's not rocket science, for lack of a better term. You can start out, you can build your own PC, you can throw in a GPU, and you can download a model from the internet, and you can train it. So you can do it, anyone can do it. It doesn't require, well, maybe somebody with access to MIT or Stanford level resources. And unless we do that, we're not going to be able to get this kind of generalization, whether it's across age boundaries, across geographical boundaries. Certainly in terms of geography, we have models for pathology trained with data from New York City that are definitely not going to be very good with data from Beijing. So the idea that everybody has to be part of the solution, I think, has been mentioned before at the conference, and I think it's a very important and powerful one, where we have to kind of get this message across as people who are involved in talking about AI in healthcare in any capacity, whether obviously it's physicians, people who are doing research, people who are providing infrastructure. Everybody has to work together because we all contribute to what the outcomes are going to be. And well, certainly we have more expert opinion here in terms of what the answer may be to the specific questions.
I don't know about that, but I can go ahead and try. So my name is Peter. I am a neuroradiologist by training, but I actually only practice about 1 day every week to 2 now, and instead spend most of my time directing the new Clinical AI Center at the University of California, Irvine, where I essentially roll my sleeves up and actually write code with my team of engineers and data scientists and really try to figure out how to develop AI tools that make sense for clinicians. If I were to generalize, so these two problems are in some ways very different, but there's probably some common themes that I'll try to touch on quickly and then more or less open it up for discussion. I think there's probably two key parts of the solution that we need to think about. One would be the data, because certainly in the pediatric population, there may not be a lot of data for the rare diseases that you're dealing with, and that's kind of what you're implying here. And so to go off of what you were just saying, right, data, how do we solve this problem of democratizing data and making more data available? Well, one thing, right, one part of the solution will be trying to figure out an infrastructure and way for multiple pediatric institutions to come together and actually share data effectively. And it sounds trivial, but there's actually a tremendous number of very challenging steps to get there. Everything from even properly anonymizing data, which again sounds so simple, but an algorithm that's 99.9% good at anonymizing data will still miss 1 out of 1,000 cases. And when you're dealing with the type of data we look at in AI, that's actually unacceptable. So trying to figure out how to create larger and more comprehensive data stores, I think that's part of the solution. Technically, another way to look at the exact same problem is instead of trying to aggregate data, to try to build creative ways of training models where the data never leaves any one institution, and instead have a model that's partially trained at institution A, then passed off to institution B, and so on and so forth, and train iteratively in that way where the data gets to essentially remain on-premise and safe. From a technical perspective, I think the other things we should probably think about, and sort of the thing that's close to my heart, is trying to design tools and algorithms from the perspective of a clinician or for knowing the things that we're doing. Like, so what I'm saying here is that when we look at a heart and we ask an AI to trace out all the segments of the heart on an echo, right? The power and beauty of deep learning is that I can, in theory, know nothing about how that happens and just simply ask the AI to do it, and it does an okay job, right? That's actually the beauty of end-to-end neural network advances in recent years. But in my experience, right, inherently what's going on behind the scenes is the algorithm is eventually learning some basic anatomic landmarks, some cues, the apex of the heart, the interventricular septum, things that I need to look for first to understand what all the little chambers mean, right? An AI that successfully solves this task must inherently have done all those other things too. It turns out that if you explicitly code those things into an algorithm, so instead of this pure end-to-end model, actually go through and teach it anatomy and teach it to look for anatomic landmarks. One, the task is much more objective and therefore much easier to solve. You can get away with much less data than you would need if you had a pure end-to-end approach, and you'll generalize much better, right? The rare pediatric cardiac diseases that we're talking about, right? A lot of the times when you're trying to unravel what's going on, you're actually going back and doing that exact same process of tracing out anatomy and figuring out what the underlying things are. We should have the AI tools actually do that, right? That's how we should design them. And so I think that'll go a long ways to solving both of these problems, really. An EKG is no different, right? I can gestalt and look at an EKG and say, oh, that kind of looks like this arrhythmia, right? But in reality, as a clinician, what you really need to do is look for the QRS complex, right? You need to trace out and look at the QT interval. You need to make all these measurements, and if you have an AI that does that, rather than spit out a diagnosis, your AI will do much better and generalize. So with that, I think I've opened up more for questions and places to go from here.
So I have a question for that. If you were to develop an algorithm and the pediatric heart grows as they mature, right? They go from infants to an adult. Would you have to write multiple different kinds of algorithm to help with that?
Right, so I think a general rule of thumb in AI machine learning work is that if the AI has seen something similar to it in the past, it'll do a good job, right? But if it hasn't ever seen it before, you're gonna need to give it some extra help. So I guess the short answer to your problem is that likely if you're training it purely on a very young patient population and then expect it someday to generalize to an adult, you're probably gonna have issues, right? But of course, there's no inherent reason why you can't build that sort of heterogeneity into your population. And so that's probably the correct way to solve it, is to find a very large cross-sectional distribution of patients of various ages with this disease process going on and build your algorithm that way.
How about this? Do you think it's possible to think of maybe having some kind of GitHub type of concept where you could have people have access to the partially trained algorithm, download it, train it, with instructions, I guess some kind of wiki associated with that GitHub, so that they easily can follow 10 steps for building a PC, putting a GPU in, getting their data, ETL, whatever, train the model back, upload it, and somehow with that make some notes of, overall what kind of data they used. Is that a possible model for sort of global collaboration that doesn't require PHI to leave, the hospital borders?
Correct. So it's this idea of training algorithms on different data sets, same underlying architecture and code, just switching out data sets, right? And I think that's a very powerful model for several reasons, right? One of the biggest issues that we have, and we're sort of alluding to in this problem, is generalizability. Taking one model trained on one data set and hoping that that model will work at everyone else's hospital, right? And of course, nothing else in healthcare works like that. Everything we do is customized on a hospital by hospital level. So why would we treat AI and neural networks differently, right? The solution to that would be something like you described, right? Maybe instead of selling each hospital a single model, maybe I sell a 90% trained model that's seen a variety of data, and now I'm going to give that to each institution and give them instructions or give them some sort of assistance in hyper-optimizing that network for each individual hospital's unique patient demographics or things like that. And something like a GitHub or a Model Zoo or some central repository for that could absolutely make sense.
And then you could have something like a Red Hat that could offer support for the US, but then people in Africa could just download it and maybe not pay for it, right?
Absolutely, right. So you decide the degree of customization, the degree of optimization you need for your enterprise. I think that it's a very interesting a model from a commercialization perspective too, right? Because everyone's just thinking about how do I make that one model and sell it and have that be the end all be all. But maybe it's a service that you provide. Maybe the model itself is not the kind of unique or the part of the IP I need to protect. Maybe I put the model out there and simply offer expertise and support to train it.
So what is the minimum amount of data? Okay, I'm getting to the meat of the question. What is the minimum amount of data that I need to generate to have that heart model to work?
Okay, so the $1 million question, we'll just zone in on it. All right, so from a purely technical perspective, right, pure theoretical technical perspective, there are actually plenty of models out there that people have described and shown in certain settings to train off of just one example. Okay, one-shot learning. It's a complete extreme end of the spectrum. I'm not saying it's an easy thing to do, but technically that's what we have possible. In reality, what we have in terms of practical solutions is a continuum of amount of data you need. The more limited we are in the data set, the more creative we have to get in the way we make our models. And the answer to your question is that certainly more data is good, but however much data you have right now, there's probably something we can make happen and work with it. If you have 50 cases, right, we've got to be creative, right? We don't train it the same way we train everything else. We teach it anatomy off of normal adults first, maybe. Maybe we pre-train off of a large adult echo population. Then we customize the way we do data augmentation and maybe use synthetic data or maybe use a generative model, right? Some sort of semi-supervised learning with GAN to get around all those restrictions and see how we do. We're not going to be as good as if we had a ton of data, but it's certainly something you can always get a working model out of the data that you have.
Is this on? Yeah. It makes me think that the amount of data that you need has got to somehow reflect the risk that would be undertaken if there were an error. So as an interventionalist, I do these transeptal punctures, and if a model were to get it wrong, I would poke a hole outside the heart and the patient would bleed to death and die, a child. So to me, that really should kind of drive how much data is necessary or how willing we are to take any error. to account?
Yes. So I think you're getting at a very interesting part of the equation, which is the amount of error that's acceptable for these algorithms, right? I think this is a very interesting question because a lot of current neural network deep learning work is, I don't want to say black box because it's very, I'm a scientist and there's actually quite a lot of work being done against this, but a lot of times the AI will make mistakes that don't make sense. I'll put it that, right? It's to a human, you look at it and you're like, I have no idea how that even happened, right? I think that's the part of the error equation that we need to consider the most, right? If the AI makes a mistake, but it's a mistake that I look at and say, well, I see what you were looking at this, and because of the way it was configured and because of some image artifact, it's a forgivable mistake, right? If you can design your algorithms the way that intuit and process images the way we do, the algorithms only make mistakes that are sort of forgivable and understandable. If you design an algorithm completely hands-off and ask it to do everything, and what you're left with is this black box at the end of the day. Oftentimes, the algorithm will give you those kind of crazy outputs, and I think that's the part of the equation that we need to move away from.
I think you bring up a really good point about how much error are we willing to accept, because Allison, in your example, there's a lot of error that's going to come through because of what's taking place at the time. There's no context to why that EKG is coming through, right? Patient could have just ran around the block 6 times and then goes, oh, let me see what happens, and all of a sudden, he's tachycardic, what do I do? And why is this person all of a sudden tachycardic? So I think that technology still has to catch up in some ways around understanding the context around why something is the way it is. And I know that Apple and some other folks are working on, okay, well, is the accelerometer, was it working and the person was running really fast and the arms were moving, but if the kid happens to run with their hands down like this and and they just run straight, then you have an issue. So I mean, taking that into account, I think we have to bring that into the data sets as well, and that's why, again, having a human look at that and actually help curate the data to be able to say, this is the context behind why I got this specific rhythm versus another, I think is what's going to, in the world that we live in today.
Yeah, we talk a lot about.
Oh, it's right here.
I know. Oh, there we go. We talk a lot about this idea of provider discretion, right? So we generally approach this from the perspective of, we are providing you intelligence. We are not providing you a decision. And so what we're trying to do is quiet the noise, give you an insight that's probably coupled with many other insights, and enable you to make a decision either more quickly or with greater information or at a time that's more relevant. And so that's one way that we've been able to drive adoption of using our insights with our clinicians, is that they understand we are not approaching this from the perspective of trying to replace your discretion. This is really meant to be a tool that empowers you with information and insight.
Right, I think multiple sessions today, we touched on the theme of AI being in a state currently where the computer plus the human will always do more than a computer for healthcare, right, for this specific application. And it turns out the things that AI is not good at is this idea of context that everyone was talking about, context. If I see a head CT and it looks completely normal, no findings at all, and the patient's a 20-year-old otherwise healthy person, then it's a normal state, right? But if it's a 70-year-old that comes in with unilateral weakness, a completely normal head CT means stroke. I mean, that's absolutely compatible with stroke, and it's time for TPA. So that's, I think, the value added right now of humans, right? Being able to take into the context, to talk to my other clinical colleagues, to synthesize the picture, and then use the AI specifically to help me do a particular slice of the problem that I need to solve.
And we always talk about this idea of the intent of the model, and that models are designed with a specific intent, and that it's not like a math equation where you can just plug other data in and get, and so similar to what you're doing with the heart model. And so we've been very specific and judicious with the way that we both document our models and their intended purpose and who can actually use them and have access to them.
Yeah, and that goes to some people don't like talking about artificial intelligence, and I like the idea of augmented intelligence, right?
yeah.
Right.
It's exactly what you're saying, but just labels matter, right? And for a lot of people, I think that makes a little more sense, because then it's not like Terminator's gonna kill us all.
Right?
Yeah, people are much more comfortable with the phrase augmented or like supplemental to your insight. Yeah, and so it's really this idea of we genuinely see AI as a tool that you are using to increase your degree of insight and to have more rapid decision making. Yeah.
So I think we have time for maybe one or two questions before we. One question. Close enough.
If you gave 20 clinicians the information that someone's going to fall within the next 20 days, and you might have multiple different etiologies, when you said it was a drug, but there might be others, I'll bet you get 20 different reactions from the clinicians unless you've set up some program for what they should do. And you haven't talked about that at all. You kind of said, oh, we're just giving you information. But I think you need another step in there, and I'd like to hear what you've done about that.
Yeah, so I can briefly say that we've rolled this out for our internal clinicians, which is a small cohort of clinicians with workflow of this is what you do when you get these alerts, before we give it out to the PCP and everyone else, because I can't expect the primary care to get an alert and say, well, okay, well, what am I supposed to do? This is going to fall. Why, do I? And quite frankly, all due respect to our colleagues, some of them care and some of them don't. That's why businesses like mine exist, is that we have to help augment the overburdened clinicians by adding an extra layer. So we've started with our own internal staff and the training of our own internal staff of what to do when you get these alerts before we move out. And we're still in that stage right now.
And an interesting byproduct of the clinical command centers is actually identified areas where we need workflow. And it's actually brought us to a point where we're hiring different skill sets. So we have health coaches now, and we have case management working. We have several different layers of case management based on acuity. And so a byproduct has been identifying additional workflows or work streams or jobs to be done from what we're able to learn about. Yeah, making it an insight's only as valuable as the action. And the other reason why this is important is if we can understand what intervention or action you're taking, that actually helps our model get smarter too.
Fantastic. Thank you very much to our panel. Round of applause for them.